Hello, friends. Today we are in conversation with Dr. Meg Doherty, Director of the Department of Global HIV, Hepatitis, and Sexually Transmitted Infections Programs at the World Health Organization. An epidemiologist and infectious disease specialist, Dr. Doherty has more than 25 years of experience working in the sectors of HIV and infectious diseases, including leading WHO's normative and programmatic work focusing on expanding HIV treatment to all and reducing inequalities in access to the most effective antiretroviral drugs for people living with HIV. Welcome, Meg. It is indeed a great honor and privilege to have you with us today.
Well, thank you very much. I'm really appreciative of having this opportunity to discuss some of the important questions on the agenda in advance of going to the AIDS 2024 meeting, but really also on the eve of the World Health Assembly that starts next Monday. So thank you for having us.
Rightly so. Yes, very opportune time. Meg, we are more than halfway through to achieve our goals of ending AIDS as a public health threat, ending viral hepatitis, reducing STIs and deaths related to them by 2030, along with all other SDG targets that, of course, include ending tuberculosis as well. Can you please share your reflections if we are on track to achieve these goals, that is to end AIDS, end viral hepatitis, as well as sexually transmitted infections?
Well, thank you. I think it's a really important question, and it's very timely because, as a matter of fact, yesterday we were able to share a brand new report that's on our WHO website that is looking at the implementation of our global health sector strategies on HIV, hepatitis, and STIs, and assessing both the progress and the gaps. And I guess yesterday after our session, we would end with, well, we have some gaps, but we're optimistic that we have the tools to be able to try to reset ourselves on the right pathway to reach both our 2025 targets and our 2030 goals. So from our report, and I invite you to, we can put it in the chat or share with your listeners, that what we've identified, and we've looked at the targets we set in our global health sector strategies in 2020, where we are now today, 2 years in to our strategies, how close we are to the 2025 targets, how close or far away are we from the 2030 targets. And it's a mixed picture. For HIV, we've done very well in terms of increasing our service coverage. Access to testing, treatment, and viral load have really come up, and we have more than 75% of people living with HIV having access to HIV treatment or antiretrovirals, and we have a good number of people, and among those have a very high level of viral load suppression. But when we look at what we call our impact targets, the number of people who are dying from these infections, the number of people who are getting new infections, we are off target. So overall, across these 3 infections, we have reported now in our new report 2.5 million deaths each year. And this also reflects in hepatitis that we've seen an increase in the number of deaths per year up to 1.3 million in 2022, driven primarily by hepatitis B not having adequate access to both testing, diagnosis, and treatment. In terms of STIs, and I know we'll get there as well, it's the one area where we think, we've been ignoring STIs for a long time. So we shouldn't be surprised that we're concerned about STIs. But in this report, we see that out of the new data that we have around incident or new infections for syphilis, rather than going down, they've gone up by 1 million over the last year. So we should have been moving towards less than 7 million cases of syphilis each year, and we are now at 8 million new cases of syphilis this year. And that's linked to then increases in congenital syphilis and syphilis deaths. So it's a mixed picture. I think we have a lot of important things that we know we can do for these 3 infections. But we also have a lot of work to do if we were going to get back on track to reach our targets by 2025 and 2030. Apologies, I'm not hearing you.
Thank you. Yes. So we'll come to STIs and viral hepatitis a little later. But first of all, I would really like to applaud the brilliance of initiatives like achieving the 95-95-95 targets by 2025 for all people living with HIV. And also ensuring that U is equal to U. Undetectable equals untransmittable. And in fact, from what I know, I think there are 5 countries that have already met the 95-95 targets. Botswana, Eswatini, Rwanda, Tanzania, and Zimbabwe. And I think there are 16 other countries that are close to doing so. So, which is a good sign. But globally, what is the progress on delivering on these goals by 2025? And how can one accelerate them?
Well, thank you. I think this is really, it is the sort of the glass half full view of what we've done with HIV. I think over the last 20, 30, 40 years, there's been such an investment and such a critical sense of, you know, we need to work together to be able to ensure that people no longer die from this really terrible disease, and that we do have ways of testing, we have ways of treatment. And once on treatment, the goal of remaining virally suppressed and having an unsuppressed viral load or undetectable viral load would be important, so that people know that they can you know, have good relationships and not have fear of passing along the virus to sexual partners and even to children for mothers who are infected. So I think there's been so much progress there. And yes, I think with the support of, you know, having good policies and good recommendations that come out of WHO, we have a single very well tolerated first-line antiretroviral treatment. We have self-testing so people can be tested on their own and identify their status. So many good policies that are in place. And certainly we have the support of PEPFAR and Global Fund that are helping countries financially and with programs to be able to scale up HIV testing, treatment, and care. So of the 5 countries that have reached the 95-95-95 targets, it's excellent. But we still see in some of those countries new cases among certain populations, whether it's among young adolescent girls and young women in sub-Saharan or Eastern Southern Africa, or in key populations such as men who have sex with men in all parts of the world, or people who inject drugs. So even reaching those 95-95-95 service targets doesn't mean that we've reached the elimination or the end of AIDS as a public health threat. And of those other 16 countries that are coming along and doing well, I would ask you and your reviewers to take a look at our new report, because we do have at least some categorization of countries in our annex that are looking like they're on track to reach the targets by 2025, or with a little extra help, they may reach the targets by 2025. But we also have a handful of countries where we're noting that they're off track and where we need to do a lot more work. And these are sometimes in countries that have lower absolute numbers of people living with HIV. So it means that there needs to be extra political commitment and community commitment to ensure that the same approach to having access to testing, access to treatment, access to viral load testing and being suppressed is there. So we do have a handful of countries where WHO feels we need to really ensure that they are supported well to reach those targets. And it may be, as we know, as we move forward, it may be that we have to do much more work with populations that are left behind. Key populations, men who have sex with men, transgender persons, people who inject drugs, people's in prison, people who sell sex, because they often get left behind in the response. And certainly that's part of the reason why these countries may not be reaching their 95-95-95 targets. The other things that we've seen in certain countries is that the countries may not be accessing the lowest price treatment regimens. And that's another thing that could be assisted as we assist those countries to try to reach their targets. So overall, there's been a huge amount of progress. And our goal now is to ensure that HIV and all those gains made are not lost, and that they stay on the agenda in this increasingly complex world. And that for those countries who are not yet on that pathway towards reaching the targets, that we give extra support so that HIV is at least, there's a greater sense of urgency to try to reach these targets in those countries.
Thank you, Meg, for that. And I hope the same is carried in the field of TB. How can I not talk of tuberculosis when we are talking of HIV, and we still have so many people dying of tuberculosis, not of the HIV. So treating prevention, treatment is prevention in both, and combination prevention also in TB. But why that is not being taken up by the TB community that seriously, as we find the seriousness in HIV? That is my personal stake. What are your insights on it?
Well, thank you for the question. It's complex because I don't represent the global TB department. And but I do know we have had such a strong interaction and set of combined and common goals with the tuberculosis field and group. And I think there's also a growing civil society within tuberculosis who are demanding more. And if I didn't mention it earlier, I mean, many of the gains that are happening in HIV, including the countries reaching 95 targets, are because people living with HIV affected communities are demanding that their governments and their partners and the international communities support them in what they need. And I think for tuberculosis, we have very many ambitious targets. More than 90% of people living with HIV having access to TB preventative treatment, ensuring that we're reducing new infections of TB among people living with HIV, ensuring that we are testing bidirectionally in each of the settings, co-locating the services or having them fully integrated where it makes sense. And from the HIV perspective, clearly there's a need to be working with our tuberculosis colleagues in country, in regions, globally, because we have a shared mission and we can only get there if we work together. And secondly, because we know most of the deaths that are still occurring among people living with HIV are occurring due to tuberculosis. We thought that with the rollout of what we call the Advanced HIV Disease Package, which includes using TB preventative therapy, that we would start to see a reduction of deaths due to tuberculosis, but we haven't. And so we need to be doing much more with our tuberculosis colleagues in countries to address diagnosis of tuberculosis, ensuring adequate short course treatments are available for people living with HIV, and even the TPT short course preventative therapy, which could be 1 month or 3 months. We know that people living with HIV may not be accessing that shorter course preventative therapy to the level that we would like to see. And that might also help us reduce those deaths, because there's certainly preventable deaths. I think the other thing is perhaps working on our TB and HIV collaborative work. You're giving us some great ideas. Should we be coming up with new message, renewing our commitments, renewing our language around sort of the U equals U message of TPT use will prevent further TB infection and reduce deaths. I think there's so much we could do about having maybe some better messaging, and we look to community to help us with that. And also, we can always learn from the community, and some of the best ideas, like U equals U, came from
Yes.
community messaging. So I guess that's a call out to your audience to help us and to come up with some messaging that could help us do a better job of ensuring that we're addressing both TB among people living with HIV and preventing TB in
Yes.
people living with HIV.
Thank you. Because U equal to U, I think, is very much applicable in the field of tuberculosis also. And one thing I have found, Meg, that there's a lot of treatment literacy in people living with HIV. Definitely, like even in a country like India, I have been talking to even illiterate women of the villages, and they are very well aware of what they are taking and what the medicine is about. I have found a lot of treatment literacy per se, as compared to TB. I think HIV has been brought down to the level of more of community engagement and involvement. So that is for sure. That is one thumbs up for you and for all the work you have.
Well, I think that also then begs us, what are we doing in terms of our messaging around TB, where we could really be broadening within the community. And, it's always difficult to talk about other diseases or other problems because, but I think as we learn more and more about people who continue to die from AIDS when they shouldn't, it's going to be focusing in on TB and how can we, and some other bacterial infections, and how can we prevent those, and how can we stop those when we know that many of them are very preventable. So happy to think about how we can increase that literacy in the community members about tuberculosis.
Okay. Thank you. Yes, you talked about sexually transmitted infections and how they are on the rise. Somehow we find that STIs other than HIV have been under a shadow of sort of a partial eclipse or something for quite some time. For example, India's National AIDS Control Organization, NACO, what we call, is for both HIV and STIs. But generally, people relate it with HIV program care and control. So they think that NACO just has an HIV program. Disease burden wise, STIs are very alarming. So how to respond to this? How to include STIs also as important as HIV?
Well, I love the analogy of the partial eclipse, because I think you're speaking to the converted here in our department. Even though our department is supporting HIV, hepatitis, and STIs, we're often referred to as the HIV department. I think it's it's unfortunate that we haven't globally embraced sexually transmitted infections as much of an urgency as we had with other infections. And I think it may be a lot to do with the fact that people believe STIs can be treated. But also in our conversation yesterday, we had a really wonderful insight from civil society members stating that this is the one place where there's even greater stigma and discrimination, that people would like to keep their sexually transmitted infections quiet. They'd like to maybe go to a private sector, go to a friend, go to a nurse, take their antibiotics on their own, and not have to share that, or because often many STIs are self-limiting, or with treatment can be treated in a few days to a week or so. So I think it's unfortunate because we do know that there are some STIs with major consequences. We have 4 curable STIs that we follow regularly in WHO, which is syphilis, chlamydia, gonorrhea, and trichomonas. But there are many others affecting many people around the world: HPV and the associated cancers, cervical cancer, anal cancer, throat cancer. We have also HSV, herpes viruses that, there's all concerns for many years about how that can be an interacting cofactor with HIV acquisition. So, there are so many STIs. And let me just break it down to, those that have associated deaths has been primarily syphilis. And to be honest, we've had many, many years of treatment of syphilis with penicillin to reduce onward transmission from mother to child. Congenital syphilis can be a killer for the newborn infant. And it's really a breakdown of public health programs if we're starting to see congenital syphilis on the rise. And our report shows us that this is the case. And so we know that the public health systems and programs for STIs somehow over the last 10, 20 years around the world have not gotten the attention that they need. And so therefore testing may not be happening for women who are pregnant for syphilis. We may not, people who have syphilis or have other STIs may not be recognized or counted in data systems, so we don't have a good, strong sense of what's happening there. And there's also been some problems with accessing penicillin, the best penicillin for treatment of syphilis in some places of the world, not everywhere. So my sense here is that syphilis has been a major problem, but we're not raising the bar, raising awareness. From our report, we report that we have 1 million new STIs every day. And many of them are treatable, curable, preventable. Using condoms, talking about sex with sex partners, getting treatment and sharing that treatment and ensuring that your partners have treatment. All of that should be part and parcel of our response to STIs. And so from the WHO perspective, we're really trying to raise that awareness. We're trying to build a civil society around sexually transmitted infections. We're trying to keep it on the agenda, and we're looking very much at innovations, especially innovations that have come out of the COVID time, where we know things can move quickly, where we can get better diagnostics available so we can diagnose STIs well, and better treatments, and certainly vaccines. We see that there could be really great innovations around vaccines to prevent new STIs and to use potentially even treatments like doxy-pep in people in real high seasons of risk to prevent onward acquisition or transmission of STIs. So there's a lot of work that we need to do there, but there's some great opportunities as well.
Coming to viral hepatitis, India has the second highest burden of, I think, hepatitis B as well as hepatitis C. And it's, Meg, for me, it's very disheartening to note also that the HPV vaccine is there for girls. And you mentioned vaccines just now, but vaccines remaining in boxes are not going to help us till they are actually made available to those who need them. And I think very few countries have the HPV vaccine for girls in their national program. I think we can, at least in the Asia Pacific region, we can count them on our fingers. So what are the main challenges in controlling viral hepatitis and again, making what is there, making it available to those who need it?
Well, great. Let me start. Maybe I wasn't sure if you asked also about human papillomavirus vaccines. Let me touch that, and then I'll come to hepatitis B.
Yes.
But HPV vaccines or human papillomavirus vaccines are now, and thanks to India, we have a much cheaper one-dose vaccine for girls. And even WHO, what we call our SAGE recommendations, have recommended that we can use this. I think for a period of time, the vaccines were not available everywhere, even though there are recommendations that girls starting at age 8, 9 should be able to have access. But we've seen steady increase in incline in coverage, and I'm just trying to look for the actual coverage in our report because we do talk about that. And we have, I'll find it in a moment, but increasing coverage of HPV vaccine for young girls. And I think that's important because that will prevent cervical cancer later in life. But we also are starting to see some parts of the world have also made recommendations that HPV vaccine can be used for boys. We also have recommendations that HPV vaccine, human papillomavirus vaccine, can be used for people living with HIV to prevent cancers associated that can be at much higher risk among people living with HIV. There's a higher risk of cervical cancer, there's a higher risk of anal cancer. So these are the kinds of things that we'd like to see. Completed doses right now for females who received a single dose are somewhere in the coverage of 21%. And so that's actually going up, but not yet at the 70% that we would like to see for our targets. And those completed doses for males is still around 5%. So I think there is an awful lot of work that we need to do to increase coverage of human papillomavirus vaccines. And that, again, is a real priority for our Director General. He has a whole initiative on cervical cancer elimination. And certainly for us, we also like to ensure that people living with HIV, women living with HIV, have access to this vaccine and to screening and treatment as well. Now, going on to hepatitis, a huge issue. Our new report on hepatitis, which was launched in April of 2024, show that we are still having too many new infections of both hepatitis B and C. Currently, we have 304 million people living with hepatitis B and C around the world, 50 million who are infected with hepatitis C, and the others infected with hepatitis B. And why do we have so many? It's because hepatitis B, we've had a vaccine for so many years, and it's been integrated into what we call the Essential Vaccine Program, or EPI program, the vaccine schedule. But it requires 3 doses when the child is young, but also a birth dose. And that birth dose is so important because if the mother is a chronic active carrier of hepatitis B, that birth dose will really have the strongest influence on reducing the acquisition of hepatitis B for the infant. And what we've seen around the world is we don't have enough countries that are implementing fully that hepatitis B birth dose vaccine. And where we're having some of the highest numbers of hepatitis B is in countries that don't have that vaccine. The greatest problem right now for that vaccine acquisition or having that vaccine available is in Africa. But I think in India too, what we have just put out also, too many recommendations, but new recommendations for hepatitis B include increasing access for pregnant women to be on therapy to reduce the transmission, to have treatment for their own health, but also reduce transmission to the newborn, and also to increase access of treatment for the general population with hepatitis B, as well as increasing and ensuring that there's the Hep B birth dose vaccine. Taken together, those 3 interventions should actually help us reduce new infections and reduce deaths. But the problem we have right now, for hepatitis B, only 13% of the people around the world know they have active hepatitis B. So people are unaware, kind of like in the early days of HIV. And of those 13%, 3% are on treatment. So we have, again, the same problem of linkage to care. People are not accessing the treatment. The other problem we have is that countries are not purchasing the lowest cost or the best access price for the treatment or for the tests. So tests should be running around $2 a test or less. And treatment should be $30 a year or so. And countries are paying much more. So if they pay that much more, they're not going to be able to serve as many people. So it's a multi-pronged problem that we've done so well with HIV, where we've got the access prices to testing and diagnostics, the access price to treatments, and then we were able to scale up. We have to do the same with hepatitis B and C, because otherwise we're only serving a really small proportion of the population who's infected. And again, my other comment about STIs, surprisingly, I think for hepatitis B in particular, there's a huge amount of stigma and discrimination, especially in families. They don't want to talk about hepatitis B because perhaps they've been told all along there's nothing that can be done. But at least now our new guidance and guidelines are saying there are things that can be done. You can test. You can have treatment. You can prevent it from being transmitted to your child. So take action. Not knowing is not an option now.
Rightly so. So that the word has to spread and the message has to be spread. So, and as you said, people have to start demanding. So unless they know, how will they demand? That's important. Meg, how is antimicrobial resistance affecting all the gains we are making in controlling HIV, STIs, and viral hepatitis? We've been hearing of multi-resistant gonorrhea now and elsewhere also. So
another good question. I see it as, again, I'm very optimistic. I think knowing about antimicrobial resistance allows us to have a good public health response to it. So for surveillance, we've been having good surveillance systems for many, many years around multi-resistant gonorrhea, something where we have multiple, up to 87 different sites around the world or countries that are reporting in on multi-resistant gonorrhea. And we have a few countries now that are starting to show increasing resistance to the last line of therapy, which is ceftriaxone. But in response to that, our STI team has changed the treatment for resistant gonorrhea, so that we can start to see countries sort of control and not spread those multi-resistant gonorrheas. But the other thing that we're doing in our work around gonorrhea and STIs is not only setting up surveillance, but also changing guidelines when needed, advocating for good communication and knowledge and sharing that knowledge, ensuring that there's good stewardship of antibiotics, and now actually working for better regimens to come forward for gonorrhea. So it's exciting that there's at least 2 new medicines that are coming out for gonorrhea that could be able to address that resistant gonorrhea. And so we're working very closely with those who are developing those drugs, so that as soon as we can, those could be identified as how they could be used in country recommendations and guidelines, so that we can ensure that people are kept safe from the multi-resistant gonorrhea. For hepatitis, we haven't seen a lot of resistance yet, but we're doing surveillance to keep an eye on it. And then lastly, for HIV, we've been doing surveillance for many, many years.
Yeah.
And I think right now we're reassured that dolutegravir-based regimens are still, the working horse of the HIV treatment. Integrase inhibitors are so important, whether it's dolutegravir or bictegravir, but our recommendation from WHO has been a combination of tenofovir, lamivudine, and dolutegravir. It's working well for almost everyone, but we have seen in certain settings and that if not used properly, or if it's used in people who've had a lot of different regimens in the past, there could be resistance developing to dolutegravir. So we're very careful that we want to protect that regimen and make sure that we're looking out for areas and parts of the world where there could be problems with in the future. And what that means is we just need to have a second line regimen ready. And as always, we're looking for what's going to come down the pipeline as new regimens that might be able to be an alternative in the future. But right now, dolutegravir is working very well for the majority of the people, and we're very pleased to know that it's worked so well for so many years.
Meg, I would love to hear your comments on gender inequality impacts responses to all HIV, hepatitis, STIs, as well as TB. Because
well, I think around the world, we've always been very concerned that women, children, adolescents are ensuring that they have equal access, equal rights, equal, that those inequity barriers are removed in all of the programming that we do. And I think it is across HIV, hepatitis, TB, and STIs. And some of the rights that we've gained over the last 20 years feel like they're eroding. So from WHO's perspective, we're very keen to see that we continue to work with countries who may be more conservative or having more conservative laws come out, that we work with them to ensure that services are maintained, that people have access to treatment for testing, and that health is a human right, and that nobody should be denied access to health care based on their gender, based on gender identity. And so I think we're very concerned about the world at large right now. And so all I can say is that we are working very hard to ensure that we don't fall backwards or have greater erosion of some of the rights that people and women in particular, young people have been able to achieve over the many years in the HIV arena. I would just say one area where this is particularly important is in the work that we do around triple elimination. And there are many countries who want to put forward a dossier to WHO for validation of the elimination of HIV, hepatitis B, or syphilis from mother to child. And I think part of that discussion that happens with the country is around their human rights and gender equality issues and laws. And if they can't achieve these elimination targets and be certified by WHO without achieving a certain level of equity and equality in around some of these important gender issues. So it also includes migrants, people who are living in a country who are non-citizens, and ensuring that women have access to the care they need. So in some cases, this has helped countries move forward with some of their health and human rights challenges to be able to rectify those on the pathway to getting validated for elimination of mother-to-child transmission of HIV. It's not a full solution, but there's been some cases where it's been very helpful. And because that process in of itself requires community, women, people to be coming together to be able to say, this is what's happening in the country, and we want to do better for everyone in the country.
Yes, rightly so. And generally, I have seen that HIV programs are people-centered, rights-based, and gender transformative. They use those approaches. Should the same thing happen if we are to control STIs? More people-centric and rights-based approaches there as well?
Absolutely. Yes, absolutely. I think this is one area that we are trying to develop more, certainly in our department, but as a program that would touch partners, that would touch regions, would touch countries. We believe that it's important that people feel like they're in control of their health, and that there are a lot of good examples of what we've done sort of in our technical guidelines. We have self-testing, self-care, self-sampling or self-collection of samples for STI testing. So there's a lot of what we'd like to instill is some ownership over, choice, but also times and how to become aware of an STI and treatment for an STI. But I think also it's the person-centeredness we also use when we think about anybody coming into a health center, going for primary health care. They shouldn't have to raise their hand and say, I really need to be tested for HIV, hepatitis, and hepatitis B and C because I think I'm at risk. There should be an offer. And one area that we've thought a lot about is multiplex testing, offering somebody, would you like an HIV test, syphilis test, hepatitis B, C test? Is there anything else you would like to be tested for? Let's get it done all at this moment so that a person doesn't have to have a high barrier to have knowledge about STI infections, for example. So absolutely, we'd like to see more person-centered approaches with STIs. And in advance of the AIDS 2024 meeting in Munich, we'll be having a pre-meeting on STIs to reinvigorate and really put the STI discussion on the agenda of how can we ensure that STIs, which the numbers are going in the wrong direction, how can we change that trajectory? How can we bring a greater civil society to bear and into the discussion? And I think any of those sort of person-centered approaches, we would be very happy to hear from people about what they would like to see WHO recommending as we move forward.
So you mentioned AIDS 2024. So we want to know your message, because for AIDS 2024 could be a cliched question, but definitely we need people like you, Meg. And it always, fills me with a lot of energy when I see a woman at the helm of affairs. You may say that I'm being partial or whatever, but it gives me a lot of hope. So your message for AIDS 2024.
Well, for AIDS 2024, well, thank you. I'm also, I get energized as well when I see people and leaders who are still there fighting the good fight, I would say. Many of us have been here working in the field of HIV or infectious diseases for 20, 30 years. So we can't let ourselves get too worried about the fact that we have still so much more work to do. That's the purpose. That's what gives me energy. So going into 2020, AIDS 2024, I would say this is a time for all of us to, it's a time to re-energize the HIV movement. Certainly, it's going to be the first time that we're going to have many people in person. It's not just a hybrid meeting. They're going to be thousands and thousands of people joining together. And I can imagine a very energetic and community village. So my message is connect, reconnect, recommit to the ending of AIDS by 2030, and do it by bringing along other problems, other disease areas, because we will only get there in this new world of multiple problems out there, whether it's climate or new infections, NCDs, or emergencies. We will only do it if we're working collaboratively with others. And also, I guess my other message would be, don't lose energy. We need to work harder now, because the last, I hate the platitudes, but the last mile, it is a bit of the last mile for HIV. HIV is not going to go away. People will be living their lives with HIV for years to come. But getting to a place where countries feel very much in control of the number of new infections, and that things are going in the right direction, and countries own and ministries own their program and follow it very closely. That's an awful lot of hard work that we need to do in the next 6 years, 4 years. So I hope that we can get ourselves to a point that we have 50 countries at 95, 95, 95, and only 1 or 2 countries that need to get over the line of our goals. And I would love to be able to say at 2030 that we have a significant number of countries that feel that they are able to manage their HIV epidemic in their country, or their disease in their country, and that people are living happily and long lives with HIV, but also with their NCDs, with their other infections. So that's my message.
And amen to that. that comes true. And thank you, Meg, for a very, very informative and thoughtful conversation, and letting us know about the new report which came out yesterday. And friends, with this, we come to the close of today's program. We were listening to Dr. Meg Doherty, Director of the Department of Global HIV, Hepatitis, and Sexually Transmitted Infections Programs at the WHO. And goodbye. And Meg, I hope to see you in Munich. So
We'll see you there.
yes,
Thank you
yes.
very much.